Okay, well, welcome everyone. Thank you for joining us today for our July's webinar, Posttraumatic Stress Disorder in Youth, an overview of assessment and differential diagnosis. My name is Chad Sievers. I'm the webinar's moderator. I'm going to go over a couple of housekeeping items, and then I'll let our speaker introduce herself and what she does. So if you need to ask a question during the presentation, use the chat feature, which is found on the right side of your screen. We do this because all the phones are placed on mute. And if you'd like to earn a CU, please stick around to the very end. There will be a code given, and you'll need to make sure you email that to me. If you're watching this on YouTube and it's being recorded, we only offer CUs during actual live webinars. So this webinar is being recorded, and we will upload this presentation to our website. So I'm going to turn it over to our presenter, Tiffany West.
Okay, welcome everybody. I'm excited to give this presentation to you guys today. So I want to do briefly about myself. Like Chad said, my name is Tiffany West. I'm a postdoctoral fellow here at the University of Arkansas for Medical Sciences. I do part of my work at the Arkansas Children's Hospital Child Study Center, so I'm an outpatient clinician at the Child Study Center, and see kiddos from ages 3 to 17 here, and lots of trauma kiddos. And then I also do research and program development with Dr. Peter Jensen as the other part of my fellowship. So that's who I am. As far as the presentation today, here's a couple of different objectives that I'm hoping that we'll get through today. So my goal for everyone is at the end of this presentation, hopefully you'll be able to understand a little bit better about childhood traumatic stress. I'm guessing a lot of you already know some about that, but I definitely want to go into that some because it's important for diagnosis. I also want you to be able to recognize the impact of trauma on a variety of domains. And then finally, I want you guys to be able to have the ability of comfortably assessing and diagnosing trauma, and also being able to recognize other potential disorders that might be going on for the kiddos. So, get going. There we go. Okay, so first, and I'm going to try to breeze through some of this relatively quickly because I realize it's some information that a lot of you may know already, but I also feel like it's It's important to get the background information before you start assessing and diagnosing trauma. It's important to know what you're looking for when you're doing that. So I want to talk a little bit about childhood traumatic stress, and I have the National Child Traumatic Stress Network website listed there because that's a really good place to go to get some information, and that's where I got this information from. So just briefly, the definition for childhood traumatic stress refers to the physical and emotional responses of a child to events that threaten the life or physical integrity of the child or of someone critically important to the child, such as a parent or a sibling. And then traumatic events oftentimes overwhelm a child's capacity to cope, and they can elicit feelings of terror, powerlessness, and out-of-control physiological arousal. Just a little bit of a background on that. All right. Still trying to get used to this technology. Okay, so types of trauma. So I want to talk about a couple different types of trauma that everybody should hopefully be aware of, but quickly. So acute trauma is a single traumatic event that is limited in time. So examples of these are serious accidents, so car crashes, community violence, natural disasters, earthquakes, fires, sudden or violent loss of loved ones, separation from parenting, from parents or siblings, or physical or sexual assault. But as you all are thinking right now, I'm sure, is a lot of times the kids that present with trauma, they don't have just one type of trauma, and that's very often true. So trauma can lead to more trauma, such as removal from the home, separation from loved ones, and that gets us into then chronic trauma. Chronic trauma refers to the experience of multiple traumatic events, and these can come in a few different situations. So, for example, it might be a variety of events, such as a child who is exposed to domestic violence, is then involved in a serious car accident, then becomes a victim of community violence. But it also could be more of a consistent, long-standing trauma, such as physical abuse, neglect, war, sexual abuse, those kinds of things. And the effects of chronic trauma are often cumulative, as each event series tends to remind the child of prior trauma and may reinforce its negative impact. And this then leads us to to the other type of trauma, which is complex trauma. So this describes both exposure to chronic trauma, but also the impact of such exposure on the child. So children who experience complex trauma have endured multiple interpersonal traumatic events from a very young age. Complex trauma has profound effects on nearly every aspect of a child's development and functioning, and this is often when we see adults who were kids going through complex trauma and haven't had any significant therapy or help with that. As adults, they often present with very significant mental health difficulties. So along with this, I want to talk a little bit about outcomes of trauma experiences, because outcomes of trauma, so trauma can affect a variety of domains in children, and it's important to understand what these domains are. So when you're looking at assessing for trauma symptoms in kiddos, you kind of know which domains to question caretakers and kids about during your intake assessment. So first and foremost, I want to talk about attachment, just because for even normally developing children, attachment is very important, in as much as it is for kids who have experienced trauma. So attachment describes the relationship that a child has with their caregiver. And this primary relationship that they develop at such a young age is influential for how they develop relationships with others later on in their life. So their siblings and their friends, but even into their adult life with romantic partners and their own children. And experience of trauma can disrupt this relationship between a caregiver and a child, making it difficult for the child to trust and develop healthy relationships with other people. And this can look in a couple of different ways. So it might be where the child is really guarded and withdrawn. It also can look like the child is being overly friendly and not necessarily understanding boundaries. So for you TF-CBT folks, their hula hoop space is a little bit distorted. They're either too big or too small and not quite sure how to deal with all of that. And just one real quick caveat, this is not necessarily reactive attachment disorder. I am going to talk about reactive attachment disorder and trauma a little bit later on in the slides, but I just wanted to go over just general attachment and how that might be affected with kids who have experienced trauma. Another domain that can be impacted is biology and body reactions. So a lot of times children might experience increased physical symptoms and complaints. So a lot of times they might be complaining about headaches, they might be complaining about stomach aches, and this is something to be take note of. They also may be experiencing difficulties with sleep or eating or meeting developmental milestones. So walking, talking, toilet training, different things like that might be disrupted. They can become extra sensitive to being touched by others or other types of sensory difficulties. And their immune system may not work as well. So a lot of stressors can really impact our ability to produce what we need for our immune system to fight off illnesses and whatnot. So they might be presenting with some significant physical ailments due to that. So another domain that it may impact is controlling feelings. So children through development often have a really hard time with emotion regulation as it is, but kids who have experienced trauma have this intensified for them. So they might be more fussy, hyperactive, irritable. They may seem or come off more sad or worried or angry, so their emotions are kind of all over the place, more so than what would be normal. And then controlling behavior. So a lot of times kids come into our office because of behavior complaints, so irritability, defiance, noncompliance, all kinds of stuff. Parents often talk about how the kid's having lots of temper tantrums, crying for a long time, difficulty being happy. They refer to their kids as having a short fuse. They are triggered by even small things that may not even be related to the trauma. Their reactions are very exaggerated. So one of the things I like to mention at this point is that kiddos who have experienced trauma are often at a state of simmering. So kind of think of a boiling pot where it's just kind of simmering. You might have heard this analogy used before, but they're at a state of simmering, and so although on the outside it appears that they're doing okay, on the inside they're almost ready to boil over, and so something just tiny might set them off. So on the outside it looks to us like this kid's going from 0 to 60 in 2.5 seconds, and you're not quite sure what's going on because the thing that happened was very minor. But on the inside, that kid's already sitting at about 50. So on the inside, that kid's going from about 50 to 60, which is not that big of a jump. So just something to pay attention to in that regard. Another domain that trauma might impact is thoughts about oneself. So the kiddos might feel ashamed or embarrassed about the difficult events. There's a lot of responsibility and guilt associated with what happened potentially. They might feel unloved or unsafe, hopeless about life. They often have low self-esteem. So as I'm talking about this, I'm sure you all are starting to already recognize, oh, that looks like this disorder, or that could be mistaken for that disorder, and we're going to talk a little bit more later specifically about differential diagnosis, but starting to pay attention to those things. And then another domain is thinking. So trauma can often affect their thinking and how children might, so this might manifest in their ability to focus or pay attention. They might be disorganized, might have difficulty following directions or need directions repeated often. They might have problems learning information in school. So again, I'm pretty sure y'all are thinking, that kind of sounds like ADHD potentially. So again, we're going to talk about how to differentiate that. So part of what I want to do, and I'll try to get through this relatively quickly, but I do want to spend some time talking about the actual criteria for adjustment disorder and for PTSD, because in order to diagnose those disorders, we have to know what their criteria are and what symptoms to look for. And so one of the things I want to make note is that our field is switching from DSM-4 to DSM-5. And it has been now for a couple of years, and I think we're kind of on that tail end of switching over there. So everything I'm going to be talking about is from DSM-5 now, and I'll talk a little bit about the different changes between DSM-4 and DSM-5. Make note of that. So one of the biggest changes is that we now in DSM-5 have a chapter on trauma and stress-related disorders. So this is specifically talking about different things like adjustment disorder and PTSD and acute stress disorder. So I'm going to talk about a couple of diagnoses through there and go through their symptoms so that we know what we're looking for when we're assessing kiddos. So the first one I want to talk about is adjustment disorder. And I'm going to go quickly through these as you guys will be able to see on the slides. But adjustment disorder is the development of an emotional or behavioral symptom in response to an identifiable stressor occurring within 3 months of the onset of the stressor. So this isn't necessarily experiencing a life-threatening event or anything like that. That comes with PTSD. This is just more a significant stressor is going on in the kid's life that is causing them some difficulty in adjusting. These symptoms or behaviors are clinically significant as evidenced by one or both of the following. So marked distress that is of proportion to the severity or intensity of the stressor, which can sometimes be difficult to determine in kids with their developmental age what the appropriate responses are not. But the other one is significant impairment in social, occupational, or other important areas of functioning. So even if you're not quite sure if the distress is significant enough, you usually can tell if their impairment has been impacted significantly. So are they having difficulty in school? Are they having difficulty relating to people at home or out in their community or at church or just different things of that nature? The symptoms do not meet criteria for another mental disorder. Symptoms do not represent normal behavior. So, for example, a 2-year-old who's struggling with potty training, that's pretty normal behavior at that age, but maybe like a 9-year-old who's struggling with potty training or having accidents, not necessarily potty training, but having accidents or reverting back or different things like that. That might be more abnormal that we want to pay attention to. Once stressors or its consequences have been terminated, symptoms do not persist for more than an additional 6 months. So gauging timeline in your intake is going to be highly important, and I'll talk more about that when I talk about assessment. But knowing kind of when the trauma took place, when the symptoms emerged, how long the symptoms have been lasting, and that kind of thing will help to differentiate. So that's adjustment disorder. So the next one I want to talk about is post-traumatic stress disorder, which is kind of the main one that we want to look at, or that we want to talk about in today's presentation anyway. So post-traumatic stress disorder is the exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways. And so they list the different ways that it can happen. So directly experiencing it, witnessing it happen to someone else, learning that the event occurred to a close family member or friend later. So that could, for example, be domestic violence between parents. Maybe the kid wasn't there when it happened, but the next day he sees that mom has a black eye, or Dad's leg might be broken or something where it was different the day before, and so they kind of see what happened afterwards, or they hear about it from someone else, like a sibling who may have watched it happen. And experiencing repeated or extreme exposure to aversive details of the traumatic event. So all of those constitute experiencing a traumatic event. And then the next criteria for PTSD is the presence of several symptoms across 4 major domains. So one of the differences between DSM-4 and DSM-5 is that in DSM-4 we only have 3 categories. So it's intrusive symptoms, avoidant behavior, and arousal and reactivity. But now in DSM-5 we have an addition of negative alterations in cognition and mood. And I'm going to go more in depth in those in just a second, but I want to finish off the rest of the criteria for PTSD. So also the duration of the disturbance is more than 1 month following the occurrence of the traumatic event. If the kid comes into your office and the event happened less than 1 month ago and they're experiencing, I believe it's 9 symptoms across the 4 domains, then this would be acute stress disorder versus PTSD. But if they're coming into you a month after the event took place, a month or more after the event took place, then we're looking potentially at PTSD. So it's important to know timeline in that regard. The disturbance causes clinically significant distress or impairment in social, occupational, other important areas of functioning. And the disturbance is not attributed to the physiological effects of substances or another medical condition. So it's also important to know medical history for kids. Do they have histories of seizures, head injuries, things of that nature? For adolescents, do they have substance abuse histories and whatnot? So that's also important to pay attention to. So now I want to go over the different clusters of symptoms, and I realize this might be a little bit overkill or a little bit in-depth, and you all probably know a lot of this already, but I want to be able to point out how DSM-5 has distinguished some differences and how to pay attention to some of these symptoms in kids. So I'll make note of just a couple of those. So one of the symptoms is recurrent distressing dreams in which the context and or affect of the dream are related to the traumatic event. But DSM-5 has distinguished that in children there might be frightening dreams, but without recognizable content. So they might be having nightmares, but it doesn't necessarily have to be related to trauma. Another one that's a little bit different is dissociative reactions or flashbacks in which the individual feels or acts as if the traumatic events were reoccurring. For kiddos, this might manifest in trauma-specific reenactment and may occur in play. So the kid might be playing about the night that the police came and took their dad to jail or something like that. So they may not actually be re-experiencing it, but they're reenacting it in their play. So that's a couple of differences with the intrusive symptoms, but overall with this category we're looking at any reoccurring or involuntary intrusive distressing memories, intense or prolonged psychological distress from trauma reminders or marked physiological reactions to trauma reminders. The next cluster is avoidant behavior, and on each of these slides I do have how many symptoms you're supposed to be looking for. So with this one it's just one or both of these symptoms. So avoidance or efforts to avoid distressing memories, thoughts, or feelings closely related to the trauma, or avoidance of or efforts to avoid extreme reminders of like people, places, conversations, activities, objects, situations, anything of that nature that might arouse distressing memories or thoughts about the trauma. Then for negative alterations in cognition and mood, we're looking at 2 or more of these symptoms. So a lot of this is related to maybe inability to remember important aspects of the trauma. We know a lot of times people who have experienced trauma sometimes have a hard time filing those memories appropriately in their brain, and so they might have a hard time remembering certain aspects. Persistent and exaggerated negative beliefs or expectations about oneself or the world. So this could manifest in kind of it's a dangerous world, I'm not safe kind of feelings or thoughts. Persistent distorted cognitions about the cause or consequences of the traumatic event. So this leading to blame self for that. So it's my fault that happened. I should have done something differently. I should have told somebody afterwards right away. So different thoughts of that nature. Markedly diminished interest or participation in significant activities. That's a pretty big component of depressed disorder or depression. We'll talk about that in a little bit. feeling of detachment or estrangement from others, and persistent inability to experience positive emotions. So difficulty even feeling loved by somebody, feeling happiness, feeling satisfaction. So a hard time feeling pleasurable emotions. And then the last cluster is arousal and reactivity, so are looking for 2 or more of these symptoms. So irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression towards people or objects. So again, this is the kid that's kind of on simmer and just seems to blow up for no particular reason or for little reasons that seem out of proportion for the behavior. Reckless or self-destructive behavior, hypervigilance, so kids who are just always on the lookout for danger or always, kind of checks the room out when they go into a room and just making sure that nothing bad is in there. Exaggerated startle response, problems with concentration, sleep disturbances, so difficulty falling asleep, staying asleep. So those are the 4 different domains that you guys really want to pay attention to when you're doing an assessment for trauma symptoms. But for kiddos under 6, so the DSM-5 also distinguishes some different things for kids under 6 years old, and the criteria is a little bit different for them. So one of the big differences is that symptoms are more behaviorally anchored, so kids are going to manifest more behaviors, and you want to look at more behavior stuff, because kids under 6 have a hard time articulating or letting us know what's going on in their minds, what are they thinking, that kind of thing. So a lot of times their symptoms are going to be more behavioral oriented. But they still have to meet criteria for the different domains. So intrusion symptoms, we need recurrent, intrusive, and distressing recollections of the event. Avoidance symptoms and negative alterations in cognition or mood. With this one, you only need 1 symptom in either of the categories. So you don't need 1 in both, just 1 in either of them. So they kind of lowered the threshold for the number of symptoms needed. With this, too, they've changed the wording of some of the symptoms and deleted some symptoms as well. So, for example, let's see. Some of the symptoms that were deleted from this for the younger kids include sense of foreshortened future or inability to recall certain aspects of the event. They also changed diminished interest in significant activities to constricted play and feelings of detachment or estrangement. Maybe manifested more behaviorally as social withdrawal. And then increased arousal, so still irritability and anger outbursts. So these are going to be manifested more of like extreme temper tantrums and things of that nature. That's for the little guys. Okay, so I apologize for talking so quickly. I just want to make sure I got through all of the DSM-5 criteria stuff. And just did a brief overview, but definitely did want to go into all of those just to make sure everybody was aware of them and talk about them. So to get more into the heart of the presentation, I'm going to start talking about assessing trauma symptoms. And I think this is really where the biggest piece comes from, because without a thorough assessment, it's really difficult to know what's going on with the kiddo or what's really driving the train. And when I say that, I mean what's kind of the core component of these symptoms? Is it trauma or is it something else? And that's how we get into our differential diagnoses. And so a lot of times, unfortunately, formal assessment of trauma symptoms is not common practice, but as I mentioned, it is a beneficial tool in knowing whether a child meets criteria for trauma or other stress-related diagnosis and is in need of trauma symptoms. Also, doing a trauma assessment helps assess for trauma-specific and other symptoms that may or may not be reported otherwise. So if you don't ask about it, parents aren't always going to report it. And so I've definitely, in some of my intakes, when I ask about trauma, parents kind of look at me and like, oh, I didn't realize my kid could be affected by that, or, my kid's pretty resilient, they're doing fine, that didn't bother them, or just different things of that nature. So they may not be thinking about it on their end, so it's important for us to ask about it. It's also a good observation when you start talking about the trauma in front of a kid and a parent. You can kind of see how they respond. So do they try to avoid talking about it? Are they a lot more verbose about it and kind of tell you the entire story in full and give you a trauma narrative right there on the spot? kind of how are they with talking about it, and that's a really good observation to do if you ask about it in the intake. So with assessing trauma symptoms, the interview with the caretakers and the child is probably one of the most important things that you can do. And I've listed out here a lot of the different information that's important to gather. So you definitely want to know how old was the child when the trauma happened, how often did the trauma occur, how long did it last. Were reported symptoms of concern present before, or did they worsen with the traumatic exposure? One of the really timeline, were these symptoms, do they increase in length or severity when the child's reminded of the trauma? Is there disruption in routine? So are they eating differently? Are they sleeping differently? Are they toileting differently? And this is important to note. Is it a disruption in a routine after the trauma occurred, or has there always been a disruption in this routine? So some kids always have had sleeping difficulties or always have had toileting difficulties, so it's important to gather that information. You want to gather specific information about the 4 different domains that we just went over, and that's why I wanted to go over those, because you want to make sure you pull specific questions from there to better understand what's going on. Is the kid avoiding trauma reminders? Does the kid have ever stated anything about feeling like it was their fault, or just different things like that you want to get at. And then for younger children, ask about temper tantrums, constrictive play, or the social withdrawal that the DSM-5 has put in. Measures. The UCLA PTSD scale is one that hopefully most people are familiar with. It's a brief screening tool to provide information regarding trauma exposure and PTSD symptoms. So it's the items are matched to the DSM-4 criteria still, but it still provides preliminary PTSD diagnosis information. So it still gets at those 3 core domains: the intrusion, the avoidance, and the arousal. But it also gives you an overall stress response, and I'm going to show you guys an example here in just a sec, but it's something that I believe you can find on the ARBEST website, and you can score it on the ARBEST website as well, and I'm going to show you what that might look like here in a sec. So this is what a UCLA PTSD scale score on the ARBEST website looks like, and this is a pre- and post-treatment that I had, so that's also nice that it does that for you, because this was a great graph to show the parent to see, look how your kid's symptoms have decreased after treatment. So as you can tell on the kiddo that I have here, his stress score is initially above the severe range, and he was identifying quite a few symptoms. So he wasn't exactly identifying as many intrusion symptoms, but his avoidance and arousal was pretty high. So this is just a good indicator for us to know, and it also gives you item-level symptoms. So this kind of helps me go through the different DSM symptoms to see, okay, was he endorsing this, was he endorsing that, and how extreme was he endorsing it. So that's a really handy tool to have that is provided to us. Unfortunately, though, this is only used for kids 7 and older, so what do we do with the ones at 6 and younger? There is a couple different measures. One that I have used is the trauma symptom checklist for young children. The difficulty with this, though, is it does cost money, and it requires some experience in administering and scoring. So I wanted to at least give you something that you could use for kiddos, but I recommend if that's something that's not feasible for you to use, definitely you want to use your clinical interview with the caretaker and the child, as well as your observations during the intake to determine the presence of symptoms. And again, for arousal, we need 2 or more, just 1 symptom in the avoidance or negative alterations in cognition and mood, and then 1 for intrusion. Okay, so some common questions that people might ask after they've done an assessment and things that might come up. So the parent and the child report are different. What happens when that occurs? That's actually pretty normal, so don't be alarmed if that does occur. Parents don't always often know what's going on inside the kid's mind, so they may not be able to identify as much of the intrusive thoughts and things of that nature, but they're pretty good at knowing what's going on the outside, what behaviors are manifesting. And sometimes the child, depending on their age, may not have an accurate representation of how they're feeling either. So it's definitely okay and normal if the kid and the parent reports are different. So another common one is the child seems anxious and avoidant when discussing the trauma, but did not endorse significant symptoms. I think this one also happens with our very avoidant kiddos who they don't want to talk about it, and the best way to not talk about it is to act like it doesn't bother you. And so that's also pretty common. So what I would suggest there is that's where you really want to rely on your observation skills of when I'm asking these questions and he's telling me that, nope, I don't think about it at all, no, it doesn't bother me at all. Does he look physically anxious? Does he or she look physically anxious? Are they hiding their head? Or are they talking softer? Like just all those different observational behaviors that you'd be able to note from that. To know of, I think this might be bothering you a little bit more than you're willing to admit right now, but just kind of keep that in the back of your mind. Another one is kind of the opposite of that, where the child experienced significant abuse or other types of trauma, but does not seem anxious or avoidant and did not endorse significant symptoms. So this also might be the case. So we know that kids who experience trauma, not all of them are diagnosed with PTSD. Not all of them have trauma symptoms. And so that's another thing to just kind of observe and pay attention to, okay, how are they responding? Do they really seem okay? Are they able to talk about it a little bit without getting aroused or whatnot? So kind of using your observational skills on that too is going to be important. Another one is I reassessed and the symptoms worsened. So that graph I showed you earlier, maybe it went the other direction. And that also happens because a lot of times throughout treatment, especially if you're assessing kind of before treatment and the midpoint in treatment, that may happen because you guys have been into trauma treatment, you're doing psychoeducation, you're helping them understand symptoms more, helping parents watch for symptoms more, and so they might have a better understanding of what they're going through, and so they might report higher symptoms because it's more accurate at that point in time. So I just want to go over a couple of different common questions. Okay, so now to get into the differential diagnosis piece of things. So differential diagnosing is basically just distinguishing between disorders that present with similar symptoms. Symptoms of trauma, as we've already gone over, particularly in young children, often mimic symptoms of other disorders. So they're very rigid in their behavior, they lack concentration, they're irritable, all that kind of stuff, which sounds a lot like many of our other disorders. So as such, it's important to consider trauma or stress-related disorders when diagnosing these children. And this is why a thorough assessment of trauma symptoms is important. Now we're going to go into a few of the different, and I apologize, some of my slides are a little wonky here, but we're going to go through some different diagnoses. So is this trauma or is this something else, and how to distinguish between those. So the first one I want to get back to is talking about reactive attachment disorder. And so for this one, I'm talking about it here versus in the traumatic stress piece of it. So let me back up. So reactive attachment disorder is actually part of the traumatic stress symptoms chapter of the DSM-5. But the reason I'm adding it to the differential diagnosis portion of the presentation and not the section where I talk about possible trauma-related disorders is because RAD is very rare, and many children with traumatic experiences and symptoms do present with attachment difficulties, but this attachment has not been disrupted to the point of necessitating a RAD diagnosis. So additionally, a RAD diagnosis is often accompanied by ineffective and even harmful treatment recommendations. So not to say that RAD's not a possibility, but RAD is a very, very rare possibility. And with the fact that it may result in some harmful treatment recommendations, we want to be very cautious of how we're diagnosing kids who present with trauma symptoms. And so one of the things that I'll say first and foremost is that we want to first provide a diagnosis that's going to accurately represent the symptoms that the child is presenting with. So we definitely don't want to fabricate anything, but we want it to be an accurate representation. But we also, almost as importantly, is we want to provide the people who are going to be working with this child, so all the adults in their lives, their caretakers, their teachers, their therapists, whoever's working with this kiddo, we want to provide them with accurate lens to view this kid through, and one that's going to help them view this kid in the most positive light. And some diagnoses don't necessarily do that. So, and we'll talk a little bit more about that, but I just wanted to kind of say that caveat of we want to make sure what we're doing is accurate diagnoses first, but then also what's going to help people understand this kid best. Do we want them to understand that this kid is just kind of gone through some really tough times, is having some difficulty dealing with the emotions from that, and this is manifesting in some tough behaviors? Or do we want them to view this kid as, you know, they're willfully being defiant and trying to disobey? So just kind of keeping that in mind. So now, trauma and autism spectrum disorder. So many children who have experienced trauma present as highly rigid. They have some poor social skills, challenges with relating to other people if their attachment's been kind of off, poor eye contact. They react poorly to changes in their routines. Excuse me. So they may demonstrate sensitivity to sensory information. So with this, I want to say with autism spectrum disorder and trauma, how to start distinguishing between the two is you want to consider family history of ASD. ASD is definitely biological. Not saying that every person who has a family history of ASD will also have a ASD diagnosis, but that's something to consider because it is highly heritable. But also kids with trauma don't necessarily present with stereotypic movements or fluid interests and patterns. So this is more likely an ASD presentation, so you want to pay attention to some of those different things when all the other symptoms are present. So now, trauma and ADHD, I think this is probably the most difficult one to distinguish between, just because a lot of times kids who present with trauma definitely have difficulties with executive functioning, so they're disorganized, poor planning. They also may present with attention or behavioral difficulties, so inattention, impulsivity, hyperactivity. So a lot of this, you, again, want to go back to that family history. Is there a family history of ADHD? Because that can also be heritable. Whether these behaviors worsen in the face of trauma reminders or other anxiety-provoking situations. So with the family, the home, the school structure you want to look at. So a big thing with this is, to give an example, so let's say we have a kiddo coming in who has poor concentration. That's a big concern for the parents. You want to get at, okay, is this kid having poor concentration all the time and in different situations, at home, at school, or is this kid having poor concentration when he's sitting at school and his teacher reminds him of his perpetrator in a trauma reminder kind of incident? So when are the symptoms occurring? Are they occurring more frequently as they should for ADHD, or are they occurring in context of trauma reminders and things of that nature? So you might have to dig a little bit more to kind of get at that. So trauma and behavior disorder, this is probably the #1 reason why parents bring kiddos into our clinic in the first place, is because their kids are oppositional, defiant, they're just not listening, they're having temper tantrums, they're aggressive, just all kinds of externalizing behaviors. So we can absolutely treat behavioral difficulties and work with parents within trauma treatment. And so unless there's a significant behavioral issue prior to trauma, I usually don't diagnose a behavior disorder until trauma treatment has been completed. So I kind of look at it a little bit more cautiously of, well, let's kind of treat the trauma symptoms, see what's going on there, and let's see what's left over. If there's still considerable behavioral difficulties that haven't been taken care of through that parenting component of TF-CBT, let's kind of figure out what's another behavioral program that we can work on and address these symptoms. But TF-CBT does have that parenting program, or that parenting component built in. So that definitely, a lot of times I think, helps to take care of some of those behavioral difficulties that are related to the trauma. But if a behavioral disorder is decided upon, I usually go with disruptive behavior, NOS, and that's preferred just so that we can explain the potential role of trauma in the manifestation of behavior problems. So we keep that piece of, it's probably trauma driving the train. It's not necessarily that this kid is willfully being defiant. It's just he's got a lot going on, and we need to be mindful of that. So trauma and mood disorders. So trauma diagnoses often include components of negative alterations, or they always include components now in DSM-5 of negative alterations in cognition and mood, and a lot of those are related to depression, dysthymia types of symptoms, so negative beliefs about oneself or the world, persistent negative emotional states, diminished interest in pleasurable activities, sleep difficulties, all kinds of things that are related to mood disorders. So one of the things to consider with this is, are these mood symptoms that are in excess, to what one might expect due to significant trauma? So are they above and beyond what we would think they should be given the trauma history? Also, are there any dangerous behaviors that we want to draw attention to? So is there suicidal ideation? Is there self-harm that may warrant an additional mood disorder diagnosis? And finally, again, going back to that timeline, what is the timeline of symptoms? Were they having a lack of interest in pleasurable activities, having sleep difficulties and eating difficulties, and a sense of hopelessness before the trauma occurred? And a lot of times in really young kids, we're not going to know that, so it's a little bit difficult to tease apart. But you do want that timeline, especially for older kids. Was this present beforehand? If it was, then you might lean towards more of a mood disorder in addition to a trauma disorder. Or did it happen afterwards, and is it potentially an effect of the trauma? And so finally, anxiety disorders, which is pretty similar to mood disorder. So the symptoms are different, but the way we assess for it or distinguish between the two is similar. So children who've experienced trauma may also present with significant worry, fear, physiological arousal. They present with recurrent intrusive thoughts that are kind of similar to OCD thoughts. You want to know, are these anxious symptoms in excess to what one might expect due to significant trauma, again, similar to the mood disorders? Are these symptoms related to experiences of the trauma? So are the intrusive thoughts related to the trauma or trauma reminders, or are they symptoms related to something else that's non-trauma specific? So kind of similar to the ADHD stuff. Is it happening outside of the context of trauma? And also consider if there's a family history of anxiety disorders, of generalized OCD, separation anxiety, social anxiety, that kind of stuff. So just a couple things to consider as I've been talking throughout this presentation. I've made a few key points throughout, but I want to kind of drive these points home as much as possible. First and foremost, did the child's symptoms emerge or worsen with the traumatic exposure? Again, going back to that timeline, kind of what was occurring before, what was occurring after. Can I be sure that these symptoms are independent from the trauma? If not, a stress-related disorder should be included as a possibility at least, so definitely considering it. It's often prudent to diagnose an adjustment disorder and then rule out for other conditions, so once the trauma has been resolved. So a lot of times I'll do that of, if these trauma symptoms are clearly significantly impacting the kiddo, let's do some trauma treatment, see how things are going after. So let's address the trauma symptoms and see what's left over. Did the trauma symptoms addressing the trauma symptoms, does that adequately address the other difficulties that are going on, or is there some stuff left over that we need to address? Also remember that diagnoses like ADHD and ASD are neurobiological. So that's why I was saying kind of test or assess for, ask for family history. Unless you're fairly certain that these difficulties are innate and not heavily influenced by environmental experiences, I would strongly recommend considering trauma diagnoses. If these symptoms are still present after appropriate trauma treatment, consider additional diagnoses. It's important to consider how others will view this child. So given our diagnoses, what stigma is attached to various presenting concerns? How would we like this child to be seen by others? And as I mentioned before, that's highly important. We want to make sure it's an accurate representation and not fabricated, but we also want to make sure it's something that is going to present this kid to other people in the most favorable light and help them understand best what's going on. And then what are the potential ramifications of diagnosing with a rule-out disorder after trauma treatment versus firm diagnosis? So sometimes it might be better to have kind of this rule-out while you're going through trauma treatment to keep in mind that those are symptoms you need to be aware of versus giving a firm diagnosis before addressing the trauma. Okay, so that's all I have for you guys for today. So hopefully that was helpful in at least being able to understand a little bit better about how to assess for trauma symptoms, and then how to distinguish between trauma symptoms and other childhood disorders. And I've provided some additional resources here. So the ARBEST website that hopefully everybody's familiar with, TF-CBT online training that I'm guessing probably most of you have done, but then also the National Child Traumatic Stress Network. I can't stress enough, it's probably one of the best resources to go to for a variety of different trauma-related issues for kids. So thank you.
Hey, thanks, Tiffany. We will hang out here for a little bit. If folks have questions, feel free to write those in. One person wrote in. We'll be able to get a copy of the PowerPoint, and I think we will be able to give a copy out, just with the understanding not to distribute it. We have a little disclaimer there, but yes, so we will give you a copy of the presentation. So if there are any questions, take a couple 10-15 seconds here to get those written in, and we'll answer those. And to do that, just click on the little chat bubble and type in your question. Well, maybe while folks are starting to write in their questions, I do just have a question for you, Tiffany, that I think you kind of addressed on one of your last points there, but I imagine you probably get lots of kiddos who have already come in with the diagnoses or several diagnoses. Like, how do you kind of sort through that? How do you handle that? Want to talk a little bit more about that?
Sure. That's a really good question and a tough one. So we definitely get kids who have had other, previous assessments and previous therapy and all kinds of stuff. So I definitely try to do a thorough review of records for sure, if it's possible, talking to the other clinicians or whoever else has been diagnosing, just to get an idea of where they were coming from when the diagnoses occurred and what symptoms that they were seeing, and again, trying to add to that timeline. So a lot of times parents may not fully understand where the diagnoses are coming from or why or whatever, but, so I definitely try to pay attention to and appreciate what other people have done, but I also, that's another reason why I do my own thorough assessment of maybe things have changed, maybe things are a little bit different, and I even ask the parents that too, like, is there anything that's changed or been different since this last diagnosis occurred, and just really trying to go based off of what am I seeing here and now, but respecting and kind of paying attention to what other people have said in the past. Does that answer your question?
It does, yeah, thanks. Okay, we have a question. Suspected trauma with the client. What is your recommendation for beginning to address suspicions with client and parent?
So I assume that means so parent comes in, a suspicion of this may or may not have happened to my kid. I've had that. So this, I think maybe we ask in a couple different things. So I've had a parent come in and say, well, I think my kid's been abused, but I don't know. I need you to assess for that. And I let parents know that's not my job. I'm not an investigator, not a forensic interviewer or anything. If you have concerns that something might have happened, definitely report that. We can report it together here. What are your concerns? But then I tell them, what I can do is just talk to you about symptoms, what's going on, and we can kind of base treatment around that to help treatment focus around the symptoms versus identifying whether or not a trauma has happened or not. As far as a clinician being suspicious, if a family's coming in and they're not talking about the trauma or not indicating that there has been a trauma, but you're suspicious that there's been a trauma, that's definitely happened to me as well before, too, where I'm like, well, they're not telling me right out, but I have some suspicions, and that kind of falls in the line of, do you report things, do you not, and that's something kind of for you to consider with colleagues, supervisors, how your facility handles that kind of stuff. But, I'm trying to think, like, the best way to answer that question, and I don't know if I have the most accurate way of representing that question, but I try not to interrogate the family or anything. I just try to keep working with them and being open-minded and giving them a safe place to talk, and hopefully if there are things that need to come up, they do. I'm up front with them, though, from the beginning of I am a mandated reporter, so here's kind of when I won't be able to keep confidentiality and that kind of stuff, and sometimes they choose not to say, and you just have to respect that and kind of keep moving forward with them if possible.
Yeah, Reba, if that doesn't answer your question, just write in with a follow-up question. We'll be happy to answer it. So, thank you. Okay, other questions out there? We'll stick around just for a few more 10, 15 seconds if anybody has any final questions. Alrighty, well, I'm going to go to the slide with the CEU information. So here you are. We will leave this slide up here for a while. So if you'd like a CEU, be sure to email me the code word to the email address there, and make sure you put your first and last name. So I take that information, I paste it onto your CEU certificate. So, and I think that's all we have. So we'll kind of hang out for a little bit, maybe answer any last-minute questions. But of course, if they come up after you leave today, feel free to email me. I'll be happy to pass those along to Tiffany. So.
Sure.
Okay. Well, thanks everybody.
Yeah. Thank you.